Imagine you pull up a fresh, non-contrast head CT for a patient. They're presenting with acute neurological deficits, and your working diagnosis is a classic hypertensive intracerebral hemorrhage.
Right. And in that scenario, you are totally primed to look at the basal ganglia, the thalamus, or maybe the deep cerebellar nuclei.
Exactly. You expect to find this dense pooling of blood deep within the inner architecture, right where those small penetrating arteries take the absolute brunt of systemic high blood pressure.
Yeah, that's the standard wear and tear pattern.
But then you actually look at this scan, and the hematoma is sitting entirely superficially. I mean, it's right up in the cortex in the subcortical white matter. And flanking this lobar hemorrhage is this delicate little rim of subarachnoid blood.
Which is completely wild because the geometry is just completely wrong for standard hypertensive vascular disease. The usual diagnostic framework, it literally just goes out the window at that point.
Today on the Deep Dive, we are analyzing a really fascinating stack of clinical notes to map out the diagnostic markers for vascular and neoplastic brain hemorrhages.
Yeah, we were looking at exactly what happens when the biomechanics of a brain bleed just, refuse to play by the standard rules.
Okay, let's unpack this, because we actually have a very specific case file anchoring our exploration today.
I do. We are following a 74-year-old patient who presented with the exact atypical superficial lobar bleed you just described.
And that specific spatial distribution really forces us to evaluate smaller, far more insidious alternative causes, right? Things that might have been quietly hiding in the brain for decades, completely undetected.
Exactly. The location of a hemorrhage dictates the entire subsequent clinical algorithm. When you see a spontaneous lobar hemorrhage, especially with subarachnoid extension, you have to immediately shift away from that hypertensive wear and tear concept.
So we're not looking at a large-scale arteriovenous malformation stealing massive amounts of blood flow or a major aneurysm.
No, the clinical notes direct us away from those massive structural anomalies. We are hunting for a primary architectural flaw in the microvasculature.
Right, specifically small AVMs and cavernous angiomas hiding out in the subcortical white matter.
Yeah, cavernous angiomas are basically a structural anomaly of the capillary bed. Instead of a normal transition from arterial to capillary to venule, you get this sort of mulberry-like cluster of dilated sinusoidal vessels.
A mulberry-like cluster.
Yeah, and the walls of these caverns are just a single layer of endothelium. They completely lack the smooth muscle and elastin that give normal blood vessels their actual strength.
Wow, okay. So they are incredibly fragile.
Incredibly. And crucially, there is no normal brain parenchyma interspersed between the vascular spaces inside the lesion.
Well, that lack of smooth muscle totally explains the clinical presentation, which is a huge departure from the acute high-pressure blowout of a hypertensive bleed.
Precisely. A cavernous angioma isn't facing arterial pressure. I mean, it's a low-pressure system.
So when it fails, it doesn't erupt, right? It just sort of seeps.
Yes, it seeps. And this slow, progressive microhemorrhaging alters the demographic profile entirely. We actually see this in a much younger patient cohort with a very distinct female preponderance.
And we also have to factor in the genetics here, right? Because the notes mentioned a well-documented familial clustering.
Right. It's particularly prevalent among individuals of Mexican descent. It's driven by an autosomal dominant inheritance pattern that's linked to a mutation on chromosome 7.
Okay, and what exactly does that mutation do?
It directly compromises the endothelial tight junctions. So the actual architectural blueprint for the neurovasculature is flawed from conception, resulting in these fragile, incompetent caverns.
But the mutation really just sets the stage, right? Like the actual lesion evolves based on the local hemodynamics.
Yes, exactly. Which brings us to the imaging, because the footprint these angiomas leave on a scan is just incredibly distinct.
I know, I was looking at these scans. What's fascinating here is the highly specific signature cavernous angiomas produced on a T2-weighted MRI.
Oh, absolutely. They predominantly show up in the supratentorial regions, so the frontal, temporal, and parietal lobes, though posterior fossa involvement, especially in the pons, is also pretty well documented.
Right, and on that T2 sequence, the radiologists are looking for that classic popcorn pattern.
Yeah, the popcorn pattern. It's driven entirely by the varied chronicity of the blood products inside the lesion.
Let me see if I have this right. You have this central nidus of irregular, bright, hyperintense signals mixed with dark, mottled areas.
Yep, that core represents the active, slow-flowing spaces and the methemoglobin from subacute bleeding.
And then surrounding this whole structure is a thick, totally dark peripheral ring.
That peripheral ring is hemosiderin.
Right, so as the angioma chronically seeps blood into the adjacent tissue, the body's macrophages come in, eat up the red blood cells, and degrade the hemoglobin.
Exactly, and the iron is stored as hemosiderin. Because T2-weighted MRI is extremely sensitive to the magnetic artifact created by iron, that hemosiderin ring shows up as a profound dark signal void.
It is essentially a permanent biological rust stain. I sort of picture it like a rust stain under a slowly dripping pipe. But wait, if these are often genetic, does the popcorn pattern mean someone is born with this full structure, or does it develop over time?
Well, the genetic mutation is inherited, so the vulnerability is there from birth. But the hemosiderin ring, that rust stain, proves that the bleeding happens progressively over time.
Right, it's a forensic marker. It proves this isn't just an incidental congenital cluster. It demonstrates a long history of structural failure and slow-motion hemorrhaging.
Exactly. Knowing the MRI physics behind that popcorn pattern is one thing, but translating that subcortical rust ring into a clinical presentation means looking at how the adjacent neural tissue actually responds to chronic iron exposure.
Because between 25 and 70% of these patients present with seizures.
Right, yes, and only 10 to 30% manifest with an actual acute symptomatic intracerebral hemorrhage. Another third present with focal neurological deficits.
That high seizure incidence makes total sense. It tracks directly with the hemosiderin deposition because hemosiderin is highly epileptogenic, isn't it?
Oh, very much so. As that iron-rich ring expands and chemically irritates the adjacent cortical neurons, it creates this very active focal point for abnormal electrical discharges.
But the presentation data gets remarkably complex when these lesions are located in the posterior fossa.
Yeah, especially in the pons. That area has incredibly dense real estate. Every major ascending and descending pathway, plus the cranial nerve nuclei, is packed into this tiny volume.
So when a cavernous angioma in the pons slowly bleeds, the patient develops a focal deficit, then the hematoma resorbs over weeks, they partially recover, and then another bleed happens months later.
Exactly. This mechanical cycle of bleeding, resorption, and rebleeding perfectly mimics the clinical timeline of a relapsing, remitting, demyelinating disease.
So the patient walks into the clinic and their history looks absolutely identical to multiple sclerosis.
Yes. The MS masquerade is one of the most significant diagnostic traps in neurology. The slow, low-pressure drip creates a profile that flawlessly mimics episodic demyelination.
That's terrifying. Assessing the actual statistical risk of hemorrhage requires understanding the lesion's history, right? Because the baseline annual bleeding rate is highly variable.
It is. It ranges from less than 1% up to about 6%. But that risk stratification changes dramatically once a lesion has actually demonstrated biological activity.
Right. If a patient has a symptomatic bleed, particularly in the brainstem, the recurrence risk spikes exponentially. And the data shows this happens more frequently in women, especially in the first 2 years after the initial bleed.
Exactly. But evaluating these vascular malformations highlights a massive vulnerability in standard diagnostic algorithms, specifically regarding cerebral angiography.
Right, because normally to map blood vessels, you'd logically order an angiogram. But wait, if an angiogram is literally designed to map blood vessels, how does a vascular malformation manage to hide from it? Is it like trying to detect a slowly trickling stream using a satellite designed only to track raging rapid rivers?
That is a perfect analogy. Conventional angiography relies on visualizing a concentrated bolus of contrast dye as it rapidly pushes through the arterial tree.
So it's optimized for high-pressure, high-velocity hemodynamics.
Exactly. But cavernous angiomas lack normal arterial input. The flow through those dilated spaces is incredibly sluggish.
So the contrast dye just washes out through adjacent normal vessels or dilutes so much that it doesn't even register on the scan.
Right. Their low-pressure nature renders them completely angiographically occult. Lack of documentation on a standard digital subtraction angiogram is the rule, not the exception.
So standard angiography completely misses them. Definitive diagnosis absolutely requires an MRI, or maybe delayed repeat angiography after a hematoma shrinks down.
Yes, or a histological exam of the hematoma wall if they actually do surgery. This raises an important question regarding how often patients might be misdiagnosed with MS simply because their angiograms came back clear.
Wow, yeah, that is a profound diagnostic blind spot. But there's a scenario where a superficial hemorrhage isn't just a quiet, slow drip hiding from an angiogram.
Unfortunately, yes. Sometimes an atypical brain bleed is masking something much more insidious.
Right, when the hemorrhage is actually masking a malignant tumor.
Tumor-related bleeds are rare, accounting for less than 10% of ICH cases. but their pathophysiology completely alters the clinical trajectory.
Because neoplasms, especially highly malignant ones, are intensely angiogenic, right? They secrete massive amounts of vascular endothelial growth factor.
Yeah, they force the rapid proliferation of new blood vessels just to feed the growing tumor mass.
But this neovascularization is super disorganized. The tumor-derived vessels lack basement membranes, they have zero structural integrity, and they are inherently friable.
Right, so when the tumor outgrows its blood supply, central necrosis sets in, and these weak, compromised vessels just rupture under normal systemic pressure.
The notes call out specific culprits here. Glioblastoma multiforme is the primary one. And for metastases, we're looking at melanoma, lung cancer, choriocarcinoma, or renal cell carcinoma.
Yes, mostly because of their hypervascular nature. Differentiating a primary hypertensive hemorrhage from a tumor-related one requires looking for very specific red flags.
Right, the diagnostic checklist. Papilledema at presentation is a major clinical indicator.
Because the tumor has already been establishing mass effect over weeks or months, elevating baseline intracranial pressure.
At unusual locations, like a bleed right in the corpus callosum, that's a classic sign for malignant gliomas, or simultaneous bleeds in multiple different sites.
Exactly, which suggests metastatic spread. A non-contrast CT might show a high-density ring with a low-density center, and contrast imaging will show enhancing nodules.
But here's where it gets really interesting. The biggest red flag is a disproportionate amount of surrounding edema or swelling relative to the size of the acute hematoma.
Yeah, the mechanisms of the edema are totally different. An acute hypertensive hemorrhage causes localized cytotoxic edema right at the margins, but a tumor causes widespread vasogenic edema.
It's sort of like coming across a tiny fender bender on the street, but noticing the police have cordoned off a massive 5-block radius with crime scene tape.
That's exactly what it looks like on the scan.
Right, the massive response immediately tells you the tiny crash isn't the whole story. The tumor's neovasculature lacks functional tight junctions, dismantling the blood-brain barrier.
So over weeks and months, serum proteins just continuously leak into the white matter, creating massive swelling.
When the friable tumor vessels finally rupture, the resulting hematoma is often pretty small, but it sits in the center of an entire hemisphere of pre-existing edema.
The brain isn't reacting to a dime-sized hemorrhage. It is reacting to the underlying invasive mass that's been dismantling the architecture for months.
So once we spot that massive, disproportionate edema, how do we confirm our worst suspicions?
The clinical algorithm accelerates into an aggressive oncology workup. You search for a primary or metastatic tumor, maybe deploy cerebral angiography to look for a neovascular blush.
And eventually, you might have to consider a craniotomy to surgically biopsy the hematoma cavity wall, right? Just to get a definitive tissue diagnosis.
Yes. And unfortunately, the prognosis for a confirmed ICH secondary to a malignant brain tumor carries a genuinely dismal outlook. We're talking a 30-day mortality rate in the range of 90%.
Wow, 90%. That brings up a really difficult clinical question, though. With a brutal 90% mortality rate, why even put a 74-year-old through an invasive craniotomy biopsy? I mean, does the diagnosis actually change the outcome?
If we connect this to the bigger picture, the intervention isn't strictly about treating the malignancy. It is about ruling out the non-malignant, highly treatable masqueraders.
Ah, I see. Because the common mistake is assuming a lobar hemorrhage in an elderly patient is automatically a tumor or amyloid related without actually confirming it.
Exactly. You cannot afford a false positive for a terminal disease. If you see edema, assume it's metastatic and send them to palliative care. You might miss a surgically curable cavernous angioma that just had an atypical inflammatory response.
So the invasive biopsy is mandatory to ensure you aren't condemning a patient with a manageable vascular anomaly.
Diagnostic precision is non-negotiable here.
Which actually brings us right back to our 74-year-old patient from the case file. We have that spontaneous lobar hemorrhage with subarachnoid extension.
Right, and that superficial location absolutely keeps a small vascular malformation on our differential list.
However, given their age, the lack of any seizure history, and the fact that the imaging confirms a single isolated lesion without that massive disproportionate vasogenic edema.
Right, all of that points away from both a cavernous angioma and a tumor. The clinical notes conclude that cerebral amyloid angiopathy remains the strongest candidate.
Which we'll definitely have to cover in a future deep dive. But essentially, amyloid proteins replace the smooth muscle cells in the arteries, making them super brittle.
Exactly. When those brittle cortical vessels rupture, They create the exact lobar hemorrhage we see on the scan, perfectly fitting this 74-year-old patient's profile.
This has been an incredible breakdown. We started from an unexpected surface bleed, completely threw out the standard hypertensive framework, and dove into the popcorn MRI signatures of slow-flowing cavernous angiomas.
We really unpacked how their low-pressure hemodynamics create those epileptogenic hemosiderin rings, all while staying entirely invisible to the standard angiograms.
Right, and then we explored the red flags of tumor-induced hemorrhages, where massive pre-existing vasogenic edema proves that a tiny bleed is actually the final structural failure of a hidden malignancy. So what does this all mean?
I think it leaves us with a really provocative final thought to mull over. Think about those slow-flow cavernous angiomas hiding in plain sight, just slowly ticking away, even mimicking multiple sclerosis for years.
Yeah, completely invisible to the gold standard angiogram.
Exactly. It really forces you to wonder how much of what we experience neurologically, or simply assume, is an untreatable chronic disease, might actually just be a tiny hidden architectural quirk in the brain, silently waiting for the exact right imaging to finally be seen.